and then start it. Okay. So I wrote down everything she did that one day in class at the end, when she went over what's all going to be on there. So she said from week 5, the difference between the plastic and glass containers. So knowing the pros and cons for each one. So for the plastic containers, it's easy to store, but it's harder to read and uses plasticizer, so it's not good for the environment. And um, let's see, they're easily punctured is another con. And then for the glass ones, they're not easy to store. If you drop it, they're just gonna break and be a big mess. You have to vent them to prime it. But a good thing for them is they're easy to read. Those are the ones that she hit on. I do have the workbook open though. And for the glass containers, another pro was there's no plasticizer, so it's better for the environment. And then another con was the particulate matter due to coring, and they're hard to dispose of. And then in italicist, it says glass containers require the seal on IV tubing to be opened, so that need to vent. So I feel like that's definitely going to be on there with the glass containers. Just remember that we have to vent those. Oops. What's up, Jasmine? Let's see. And then the plastic containers is a closed system, so infection control wise, they're better. My dog is totally jumping on me right now. This is ridiculous. I think she missed me. They're lightweight and easy to store. And then the other cons that they had in the book, the fluid levels hard to read and potential for leaking. So those are just some of those cons and pros of those plastic versus glass containers. The IV tubing changes. Just remember for your primary, we're changing the tubing every 96 hours. For your secondary, we're going to change those every 24. So any of those piggyback IVs or anything like that, you're going to change that every 24 hours. For any tubing that do with blood, dog, I'm gonna kill you. It's every 4 hours. I think those were the only ones we talked about for changing tubing wise. Remember your macro versus micro drops. Your macro drops are 10 to 20 GTT per milliliter. And then your micro drops are the 60 GTT per milliliter. The one way I described it was thinking of marbles. The bigger the marble, the less marbles you're going to take to fill that jar. So if you have trouble keeping the difference between, just think of marbles. And then if they're small marbles, you're going to need a lot more marbles to fill that container. So same thing with those drops. She did talk about heparin. So doing the heparin infusion, it increases your risk for heparin-induced thrombocytopenia. A way to know that is looking at your platelet count. So anything less than $150,000, or Jesus. Can you guys tell that I worked 16 hours yesterday and 8 more this morning? Anyway, anything below 150,000 platelet count is a big sign of that heparin-induced thrombocytopenia. You'd want to turn off the heparin and list it as an allergy because you do not want them to receive this heparin if their body reacts that way. So we list it as an allergy. because it does cause this thrombocytopenia. Different ways you can give heparin is through IV when you flush, or you can do IV push or infuse it, and then subcutaneously into the abdomen is the usual area of choice for the heparin. Remember what the antidote is: protamine sulfate, and then that we monitor PTT with heparin. I think we have that pretty ingrained from last term. And then we have Coumadin. Remembering that the normal range is 2 to 3. Like Coumadin is only given PO. We monitor PT-INR, and the antidote is vitamin K for Coumadin. And let's see, the other med she talked about was lorazepam. So those are 4 uses that we have already talked about this term: treating anxiety. It can be used as sedation during procedures for that CWA. So for those alcoholic withdrawals, to prevent those seizures in them, and then to bring people out of seizures. It is a controlled substance. The route you can give lorazepam is PO, IV, IM. And the big thing that we want to watch out for with lorazepam or Ativan is respiratory depression. So I can definitely see there being a question or them saying something about low respirations. Would you still give it? And obviously we would not, because that would make it even worse. Let's see. Talking about TB meds. I have no idea if I'm saying these right. I kind of wrote them phonetically as she was going over them really quick. I'm trying to see if I can find them in the book. The isoniazid, isoniazid, actually, I think is what it is, actually. You don't want to give this to liver patients because it does cause hepatotoxicity. It can cause, obviously, your nausea, vomiting. It makes them dizzy. It can cause even fatality, hepatitis. So it's just, remember with that one, it's bad for the liver, the isoniazid. Rifampin, it's Rifampin. It's another treatment for TB. It is also a bad one for the liver, but also for the kidneys. So it can also cause renal failure and then the liver toxicity as well. So anything that's treating TB, these 2 meds are bad for the liver, but then the rifampin is also bad for your kidney. So you want to be assessing for jaundice, doing hepatic studies. You want to educate not to skip doses with this medication. Let's see. So it will probably be asking questions on the checkoff we had, which I feel like most of us, have that down pretty well. So making sure you're doing good hand hygiene. It's a sterile procedure for that central line dressing. The main solution we use to sterilize or clean the area is chlorhexidine. Also knowing with those central lines, the femoral area is the last choice to put that central line due to the high risk of infection. And that they'll be reviewing that daily to see if they are still needing that central line, because the longer they have that in that femoral area, the higher risk of infection. Knowing the 4 types of central lines. So you have your tunnel cath, which is usually used for those long-term patients on dialysis, the non-tunnel, the PICC line, and then those implanted vascular devices. How often do we change the central line dressing? You're going to change that 1 time a week, and then PRN if needed. I don't know if this will be on there, but she did mention if it had gauze in there, you'd want to change it every 48 hours. It was kind of random that she threw that out there, so I feel like that could definitely be on the exam. So central line dressing 1 time a week, but if there's gauze, you want to change it every 48 hours. She said that there's going to be quite a few questions on scope of practice. I feel like for most of us, we have those down pretty well. The main thing I feel like is remembering with adults 18 and older, we do definitely a lot more, but if they're under 18, pretty much the only thing we can do is the dressing change. We can't hang fluids, we can't start an IV. So with kids, or don't forget, it's not just thinking like 10-year-olds or 5-year-olds. It could be a 17-year-old. That gets kind of tricky on those questions. So really look at the ages. And if it's below 18, if it's not saying a dressing change, then it is not going to be in our scope of practice. We can flush all needleless central lines in adults. Obviously, we can do the dressing changes on adults. You can hang certain fluids, which like isotonic and even hypotonic ones. But if there's any vitamins or electrolytes, we can hang the second bag, not the first bag. Can't hang heparin. Can't. I'm trying to think of the other ones. I'm trying to look at my paper. All sorts of disorganized again. We can hang antibiotics, so don't let that throw you off. I feel like a lot of times they'll say a fancy word, but it's an antibiotic, so we can hang those on adults 18 and older. So just really, if you're not comfortable with those, I would definitely go over those scope of practices and make sure you understand them all. The preventing infections, a good way to do that is making sure you're checking your expiration dates, removing the IV when there's redness, not spiking, not touching that spike with your fingers, I mean. So keeping that sterile. If you drop it, making sure you're getting a new one. You can't re-sterilize that. She did reiterate that a couple times, so I feel like there's probably going to be a question about that. Any tubing or anything, if you drop it, you're going to go get a new one. You're not to fan the area after you clean it with chlorhexidine, making sure you let it air dry. She did talk about precautions. So knowing the difference between the different precautions. So contact precautions, you're going to use that for like MRSA or C. diff. And that's going to be your gloves and gown. Remember, with those contact with the glove and gowns, you're going to remove those while you're in the room. You're not going to walk out of the room with that on. You're going to take it off right by the door and then walk out. Airborne is going to be your patients with TB or varicella, which is the chickenpox, COVID. They're going to be wearing a mask, but it's the certain kind of mask with the airborne. So you're gonna wear a N95 or a different kind of respirator. And then they're gonna be also like in the negative pressure room with the door shut. So making sure if there's a question about airborne precautions, you want to make sure that the door's shut, they're in a negative pressure room, you're wearing that N95. I would assume, I'm trying to remember back from first term, if you wear the gown and everything with that as well. I think you do. Does anybody else remember?
I think so.
Yeah.
It makes sense, kind of.
I feel like the only thing you don't do with airborne, no, actually with airborne, I think you actually wear the face shield too, now that I think about it.
Yeah, because I feel like it's like one step up from droplet,
Yeah.
basically.
Definitely. You wear the shield or a respirator or airborne.
It's probably goggles and then like your N95 and
Yep.
respirator.
Yeah, because droplets everything, and then but instead of the N95, it's just a regular mask,
Mhm.
which makes sense. Thank you. And then also for those, you're gonna make sure that you remove all of those but the mask in the room, especially with that droplet precautions. So you'll take your gown and gloves and everything off, but you're gonna leave that mask on until you are out of that room. Um, that stupid hand hygiene crap. I don't remember what exactly that was called, but not wearing rings or bracelets, the 1/4 inch long nails, no fake nails. I feel like that's all kind of duh things. She talked about sepsis. Labs, what you'll see for signs and symptoms. So you'll see like an elevated wet blood count, increased higher levels of lactic level, a positive blood culture. Patient will have an increased temperature, usually a high fever, change in their level of consciousness. They'll have tachycardia, tachypnea. They'll be cold and clammy. They'll have the low urine output, and their blood pressure is going to drop as well. So with sepsis, the first thing you're going to want to do is you're going to give fluids. So I think the big key thing here is that low blood pressure. You want to give fluids to bring that up. Because remember, when you give fluids, especially the hypertonic solutions, that's going to raise your blood pressure. You would not want to give them hypotonic because hypotonic brings down your blood pressure. And we'll go over those solutions again here in a minute. And then after the fluids, obviously you would then want to treat with antibiotics as soon as possible as well, which I honestly thought that antibiotics were first, but I guess you kind of give them at the same time with IV. Once again, which I feel like we have all of these down, but I'll go over them one more time. Your differences between fluid volume deficit versus your fluid volume overload. So in fluid volume deficit, you're going to see those dry mucous membranes. They're going to have poor skin tugger. I feel like I'm saying Tigger, like Winnie the Pooh right now. Low blood pressure, a weak ready pulse. You're gonna have weight loss with these guys, and they're gonna have tachycardia. But also in fluid volume overload, they're also gonna have tachycardia. So remember that's for both tachycardia. But with fluid volume overload, you're gonna have the edema, jugular vein distension. You're gonna hear crackles in their lungs. They're gonna have an increase in weight, bounding pulse, and increased blood pressure. So let's go back to those fun IV solutions that we love so much. I've got my original notes here in the book from the first exam we did with my little notes. So your isotonic solutions, those are used for trauma and quick fluid replacement and maintenance fluids. Your lactated ringers are isotonic, and those are mainly used for burns, but they can also be used for the surgery and for OB. The main ones are the lactated ringers, the normal saline, which is the just 0.9 normal saline, and then your D5W. You also have your D5 0.225 normal saline and your 5% albumin. But the three main ones are those first three, the lactated ringer, your normal saline, and D5W. Just remember, mainly used for trauma. It doesn't do a shift in fluid, so everything stays the same, so no fluid shifting. Then the next one we have is hypotonic. So for your normal salines, is anything under the 0.9. So your quarter and third, so 0.45, 0.3, 0.225 normal saline. And then remember with that dextrose, is the D2.5 in water. And then those are the hypotonic swells the cells. Oh my word. So think of the hippo swelling up, the big fat hippo. So your cells are swelling. You want to use caution with an increased intracranial pressure. And then if your blood pressure is low, you do not want to give that to them because it causes hypotension. Hypotonic, hypotension. Let's see. Then we go into your hypertonic. So any normal saline above 0.9. So you have the 3%, 10%, 15%, whatever. I don't know how much it goes up to, but just remember above 0.9. Then you have your dextrose 10 in water. Yes, it doubles there from the isotonic. And then remember, anything added to your lactated ringers is going to be hypertonic. So your dextrose 5 with lactated ringer is a hypertonic solution. Your packed red cells are hypertonic. TPN, which is that essentially food, is hypertonic. And then 25% albumin is hypertonic. My Zoom meeting is yelling at me that it's going to expire, so I might have to do more than this one. I might have to do a second meeting. It's so stupid that it limits you on time. So I have 9 minutes left on this one. So your dextrose in water, remember, increases by 2. So if you start with your hypotonic solution, the D2.5 in water doubles to the isotonic, which is the D5 in water, doubles to the D10 in water to your hypertonic solution. Remember, normal saline is compatible with most everything, so you can give blood with that one.
Wait, which one was that? I'm sorry.
For the give with blood,
Yes.
your normal saline. So isotonic normal saline is the main thing, or pretty much only thing they'll give with blood.
Thank you.
You're welcome. This might be on there again. It was on the first exam. Lactated ringer has other stuff in it. So it has dextrose, it has sodium, it has chloride, it has potassium, it has calcium, and it has lactate in it. So I remember that first exam, like, had multiple choice, what's all in lactated ringers. So if they have a high potassium, for example, or renal failure or increased lactate level, you wouldn't want to give them lactated ringers because it has potassium and lactate and stuff in there. So kind of keep that in mind with the lactated ringers, that it has other stuff added to it. So if they're saying high levels of like potassium, that should be kind of a signal like, oh, maybe I shouldn't give that. Because that's not compatible with everything either. Also remember with the hypertonic, the cells are shrinking and it's going into the vascular compartments. So you don't want to give this to people with congestive heart failure or renal failure or are having issues with fluid volume excess, because that's just going to cause even more edema in by your heart and lungs. And that hypertonic solutions are irritating to vein walls. And also that it causes the hypertension. So if you have a patient with high blood pressure, you should not be giving them hypertonic solutions. I feel like those are the main things she's hit on with those solutions. So as long as you know those, I think that you'll be okay with the solutions. It's just sometimes you kind of have to think outside of the box. It's not going to just say point blank, they have increased cranial pressure. So got to do those critical thinking skills with those, unfortunately. ABGs with compensation are going to be on this one. I feel like we did so much practice that we are doing pretty good with those. Trying to think where I put my notes on that. Just hit on it a little bit. So fully compensation, just remembering that your pH level is normal. That's your biggest thing. And then wherever your pH is leaning towards is whether it's going to be the alkalosis or acidosis, even though it's a normal range. You just kind of see which way it's leaning towards. If the CO2 and bicarb are both out of range and the pH is out of range, like Jasmine said, everything's fucked. So that's the partially compensated.
Love that.
I will love that forever. And then if the pH is out of range and then the CO2 or the bicarb is, then it's uncompensated. Are you shaking your head, Jasmine?
Yeah.
I love
My
you.
fiance just heard that. He was like, what the fuck?
Oh, goodness.
I love that
It's,
I kept it in your brains.
it's just in there forever. So that for that one, my hint was uncompensated. It's being unfriendly. So either your CO2 is not helping your bicarb come up or your bicarb's not helping your CO2 come up. So it's unfriendly. One of them's out of range and pH is out of range. As long as you know those little hints or you know Rome, you should be good on ABGs. If you guys are not, just let me know and we can do more practice questions tonight or tomorrow and I'd be happy to help you. But I feel like pretty much everyone's got it down because we did so many practice questions. Sentinel event. I feel like we have this down as well, just remembering this is a huge major issue. It's not a rash. It's not they got sleepy from this thing. It's they're ended up in the ICU. They died or they lost a limb. So pick whatever the worst option is. Let me go to the page of this next thing I'm going to talk about so I don't forget any of them. The hospital national patient safety goals, which we've been over and over. So they are identify patients correctly. So for Remember patient's name and date of birth, not a room number. Improving staff communication. So if you get test results, making sure it gets to the right person in a timely manner. Using alarms safely, not only like safety alarms, but equipment alarms on medical equipment. So on IV pumps and things like that. Preventing infections, so doing good hand hygiene, doing sterile technique. Identifying patient safety risks. So I think a big one with this one, which he keeps reiterating, is suicide. So reducing the risk for suicide is huge. Improving healthcare equity is important. And then preventing mistakes in surgery. So having like the timeout right before surgery is an example of that one. So those are all those safety goals. And I feel like we know that one pretty well. The most severe sign or symptom that occurs with low calcium is laryngeal spasms. High potassium. The most common cause for that is going to be renal disease because you're not peeing all that potassium out. So that makes sense. When you have an alcoholic, it's going to show and cause low levels of most every electrolyte. She talked about phlebitis a little bit. And she did send that little worksheet or whatever that has all those different complications of IV. So I'm definitely going to print that out and go over those because I don't have those down as well as I would like. So the phlebitis one causes there's contaminated IV cath from blowing or fanning the alcohol. You don't allow it to air dry. Not cleaning the area as long as you're supposed to. Those types of things. I'm going to stop this Zoom and start a new one, and we'll finish on that one because this one is about to time out on me because it's so freaking rude. It's ridiculous. So give me just a second. I'll put another link in our messenger chat.